Components of care and stepwise approach. Four components of managing asthma are assessment and monitoring, education, control environmental factors and comorbid conditions, and medications. Assessment and monitoring. Assess asthma severity to initiate therapy by using the severity classification chart, assessing both impairment and risk to determine initial treatment. Assess asthma control to monitor and adjust therapy by using asthma control chart, assessing both domains of impairment and risk to determine if therapy should be adjusted. Assess lung function with spirometry every 1 to 2 years, more frequently for not well controlled asthma. Schedule follow-up care every 2 to 6 hours if gaining control, every 1 to 6 months to monitor if sufficient control is maintained, every 3 months if a step-down therapy is anticipated. Assess asthma control medication technique when written asthma action plan, patient adherence and concerns at every visit. Education. Teach and reinforce. Peak flow self-monitoring may be particularly helpful for patients who have difficulty recognizing symptoms, a history of severe exacerbations, or moderate to severe asthma. Teach and reinforce taking medications correctly, such as inhaler technique and use of devices. Avoid environmental factors that worsen asthma. Agree on treatment goals and address patient concerns to develop an asthma action plan. By providing instructions for daily management such as long-term control medications and managing worsening asthma, like how to adjust the medication and when to seek medical care. Involve all members of healthcare team in providing and reinforcing education, including physicians, nurses, pharmacists, respiratory therapists, and asthma educators. Encourage educations at all point of care, like in the emergency departments and hospitals, pharmacies, schools, and other community settings and patients' home. Control environmental factors and comorbid conditions. Recommend measures to control exposures to allergens and pollutants or irritants that make asthma worse. Determine exposures and history of asthma in presence of exposures that lead to exacerbations. Advise patients on ways to reduce exposure to those allergens and pollutants or irritants to which the patient is sensitive. Consider allergens immunotherapy for patients who have persistent asthma and when there is a clear evidence of a relationship between symptoms and exposure to those allergens. Treat comorbid conditions by considering getting flu vaccines for all patients that is over 6 months of age. Medications. Select medications and delivery devices that meets patient needs and circumstances. Inhaled corticosteroids are the most effective long-term control therapy. When choosing medications, consider patient's history of response to the medications and patient's willingness and ability to use the medication. Goals of stepwise approach. The stepwise approach is used to help in deciding what treatment and circumstances each individual patient needs. For patients who are not already taking long-term control medications, assess asthma severity and initiate therapy according to the level of severity. For patients who are already taking long-term control medication, assess asthma control and step up therapy if the patient's asthma is not well controlled on current therapy. Before stepping up, review the patient's adherence to medications, inhaler technique, and environmental control measures. There are different stepwise approach for different ages. Ages 0 to 4 years, 5 to 11 years, 12 years to adult. Age 0 to 4 years stepwise approach. The initiation of daily long-term control therapy in children's ages 0 to 4 is recommended as follows. It is recommended for reducing risk of exacerbations in infants and young children. It should be considered for infants and young children who consistently require systematic treatment over 2 days per week for a period of more than 4 weeks. It should be considered for reducing risk in infants and young children who have 2 exacerbations requiring systemic corticosteroids within 6 months. Inhaled corticosteroids are the preferred long-term control medications for initiating therapy. Monitor response to therapy closely because treatment of young children is often in the form of a therapeutic trial. If a clear and beneficial response is not obvious within 4 to 6 weeks and the patient's medication technique are satisfactory, treatment should be stopped. Alternative therapies or alternative diagnosis should be considered. If a clear and beneficial response is sustained for at least 3 months, consider a step down to evaluate the need for continued daily long-term control therapy. Age 5 to 11 years stepwise approach. Promote active participation in physical activities, exercise, and sports because physical activity is an essential part of a child's life. Directly involve children 10 years and older in developing their written asthma action plans and reviewing their adherence. Encourage parents to take a copy of the written asthma action plan to the student's school or child care. Inhaled corticosteroids are the preferred long-term control therapy. Evidence demonstrate the effectiveness of inhaled corticosteroids in children 5 to 11 years of age. Adding a long-acting beta agonist has the potential risk of rare, life-threatening, or fatal exacerbations. Studies in older children and adults show that increasing the dose of inhaled corticosteroids can reduce the risk of exacerbations. The combination of inhaled corticosteroids and long-acting beta agonists is preferred on the basis of the studies in older children and adults. Age 12 years to adult stepwise approach. For youths, involve adolescents in the development of their written asthma action plan. Encourage students to take a copy of their plan to school, after schools, or camps. Encourage the adolescents to be physically active. And for adults, consider a short course of corticosteroids to establish reversibility and the extent of possible benefit from asthma treatment. Adjust medications as necessary to address coexisting medical conditions. Review the patient's technique and adherence in using medications and make necessary adjustments. Physical or cognitive impairments may make proper technique difficult. Consider the following when selecting treatment options. Adding a long-acting beta agonist more consistently results in improvements in the impairment domain compared to increasing the dose of inhaled corticosteroids. If the risk domain is of particular concern, then a balance of potential risk needs to be considered. Increasing the dose of inhaled corticosteroids can significantly reduce the risk of exacerbations. The dose may increase the potential risk of systemic effects, although the risk is small within the medium range. Exercise-induced bronchospasm. A history of cough, shortness of breath, chest pain or tightness, wheezing, or endurance problems during exercise suggests exercise-induced bronchospasm. An exercise challenge in which a 15% decrease in peak expiratory flow, or FEV1, will establish the diagnosis. It is important for asthma to be adequately controlled in order for patients to participate in any activity he or she chooses without experiencing asthma symptoms. Exercise-induced bronchospasm should not limit either participation or success in vigorous activities. Recommended treatments for EIB include long-term control therapy, if appropriate. Frequent or severe EIB may indicate the need to initiate or step up long-term control medications. Pre-treatment before exercise include short-acting beta agonists used shortly before exercise may be helpful for 2 to 3 hours. Long-acting beta agonists can be protective up to 12 hours, and there is some shortening of the duration of protection when it is used on a daily basis. Cromolyn taken shortly before exercise is an alternative treatment, but it is not effective as the short-acting beta agonist. A warm-up period before exercise may reduce the degree of EBI. A mask or scarf over the mouth may accentuate cold-induced EBI or EIB, sorry. Pregnancy. Maintaining asthma control during pregnancy is important for the health of both the baby and the mother. Maintaining lung function is important to ensure oxygen supply to the fetus. Uncontrolled asthma increases the risk of perinatal mortality, preeclampsia, preterm birth, and low birth weight infants. It is safer for pregnant women to be treated with asthma medications than to have asthma symptoms and exacerbations. Monitor the level of asthma control and lung function during prenatal visits. Monthly evaluations of asthma will allow the opportunity to increase therapy if necessary and to decrease therapy if possible. Albuterol is the preferred short-acting beta agonist. The most data related to safety during human pregnancy are available for albuterol. Inhaled corticosteroids are the preferred long-term control medications. Budesonide is the preferred inhaled corticosteroids because more data is available on using budesonide in pregnant women than are available on other inhaled corticosteroids. Surgery. Patients who have asthma are at risk for complications during and after surgery. These complications include acute bronchoconstrictions triggered by intubations, hypoxemia, and possible hypercapnia, impaired effectiveness of cough, atelectasis, and respiratory infection. If a history of sensitivity is present, reactions to latex exposure, or some anesthetic agents. The following actions are recommended to reduce the risk of complications during surgery. Before surgery, review the level of asthma control, medications used, and pulmonary function. Provide medications before surgery to improve lung functions if the lung function is not well controlled. A short course of corticosteroids may be necessary. For patients receiving corticosteroids during the 6 months prior to surgery, and for selected patients on long-term high-dose inhaled corticosteroids, give 100 milligrams hydrocortisones every 8 hours intravenously during the surgical period, and reduce the dose rapidly within 24 hours after surgery.